Thank you, Dr. McPherson. So now that we've covered some of the drugs and the basics of pain management, we'll dive more specifically into the issue of opioid overdoses. And going back to the beginning, this is really the problem that we're faced with here. We have a huge epidemic of poorly controlled pain, and also the CDC calls it an epidemic with drug abuse and diversion. So how do we balance these two issues? All right, so for every one death, we're all worried about opioid overdoses and the deaths that result, but there's a whole lot of other consequences too that we're seeing. We've got treatment admissions for drug abuse, emergency department visits, people who are opioid dependent, and then non-medical users. So you could be an abuser, a non-medical user, and you may not be dependent yet. However, it could happen. So we have the overdose consequences, which are really the most glaring and what we're all so worried about. All of these other consequences are severe and huge issues for us as well. Where are all these drugs coming from? Well, when you ask people, where do you get these drugs that you're abusing, the vast majority get them for free from a friend or a relative. So maybe unknowingly, the relative or friend may not know that someone's going into their medicine cabinet and taking their Percocet pills, but these drugs are out there because we prescribe them for legitimate patients, and then they get out into the supply. So most people are getting the drugs that they abuse from a friend or a relative. And the next biggest chunk in the green is prescribed by a doctor, and just one doctor, not necessarily doctor shopping. This slide is similar to one that Michael Bayer showed earlier. You can see that as opioid sales, the top kind of small dotted line, have increased, so have opioid-related deaths and opioid treatment admissions. So we have more and more opioids out there, and we're seeing more and more opioid-induced consequences as well. Okay, so just some statistics to kind of nail down at the scope of this problem. If we look back to 1997 in the US, there were 96 milligrams of morphine equivalents per person sold. In 2010, that rose from 96 to 710. So huge, huge jump in the amount of opioids sold in the US. That's enough hydrocodone for everybody to get 5 milligrams Q6 hours for 45 days, every single adult in the US. As many of you know, hydrocodone and acetaminophen combinations were the most prescribed drug from 2006 to 2011. And the US has only just under 5% of the world's population, but we consume 83% of the world's supply of oxycodone and 99% of the world's hydrocodone. Hydrocodone is a little deceiving because we use more hydrocodone than any other country. Other countries seem to use codeine more, but it still gives you a general idea that we're consuming a lot of opioids for a smaller amount of people. Looking at opioid sales over the 10 years from 1997 to 2007, you can see the big jumps for hydrocodone, oxycodone, and methadone shown here. Some of that methadone jump would be because we have more people entering opioid treatment as they become addicted. And we also have seen the value of methadone in treating neuropathic pain especially. So not all of this use is problematic. Some of it's legitimate, but it still stresses the issue that we see more and more opioids out there, so we need to make sure that we're using them safely and responsibly. The US, as I mentioned, we love our hydrocodone. We use over 27 million grams in the US, and if you combine the use for Britain, France, Germany, and Italy, they're using just over 3,200 grams. So it's a lot of hydrocodone here. Stepping away from opioid use in general and looking specifically at misuse of opioids, we have about 1/5 of Americans who are using opioids non-medically. And that non-medical use is costing us about $500 billion a year. That's costs associated with medical costs, treatment for these individuals, also societal costs, legal costs, but overall it's hugely expensive. We have 7 million Americans over age 12 who are using prescription CNS active drugs non-medically, and of that 7 million, just over 5 million are using pain relievers non-medically. So prescription opioids represent the vast majority of prescription drug abuse. Looking at the use of opioids in chronic pain patients, anywhere from 5 to 41% of patients who are treated for chronic non-cancer pain are abusing their opioids. So the statistic is extremely unhelpful to us. So depending on the study that we look at, it's either a really big problem or not much of a problem at all. We've got a lot to learn still about how much of a problem it is, but it's definitely something to be concerned about. We know that among patients who have chronic pain who are treated with opioids, only about 3% are going to go on to develop addiction, but their use could still be problematic, even if it's not full-blown addiction. So 11.5% will show aberrant drug-related behavior, things like early refills, losing a prescription, forging a prescription, testing positive for an illicit substance. All of those would be examples of aberrant drug-related behavior. And just over a fifth will divert the opioids, so giving them to a friend or family member, selling them, etc. Oh. Back to this slide. Okay, it's also in the handout too, in the folders. Right, okay, so there's been different studies conducted to try and identify what % of patients who receive opioids for chronic non-cancer pain actually abuse them. And so different studies have found different results. And it's been reported anywhere from 5 to 41%, depending on the study that you look at. So my point with this statement is that we don't really have a good idea of how big of an issue this is. Yes. Okay, so that's a good question. Abuse is different from misuse. So misuse would be if you were prescribed a Percocet tablet, take one every 4 hours for pain, and you decided to take it every 3 hours because you were having bad pain, that would be misuse. You're using the drug other than the way it was prescribed. Abuse would be misuse with consequences. So you're misusing a drug and you're either having legal consequences because your misuse has now led you to forge prescriptions, or it's gotten you in trouble with the law or with your employer. So abuse is misuse plus negative consequences. Okay, thank you. All right. So again, going back to the need for a balance between effective pain management and safe use of drugs, we have to provide analgesics, including opioids, to people in pain. It's absolutely not a question. We want to ensure that there's access to these medications. We have to make sure that we're doing that in a safe manner and balancing our responsible use with the growing concerns of harm. So we've heard a lot about the PDMP, and there's also other strategies that we can use to decrease opioid abuse and to decrease that risk. So as Dr. McPherson mentioned, there's all kinds of questions we can ask to assess patients for their pain and then also for their risk. So do they have psychosocial factors that place them at higher risk, or a history of substance abuse, a family history of substance abuse? Monitor aberrant drug-related behaviors that could indicate abuse. So things like coming in early for refills, repeated episodes of prescription loss, all of those can indicate that something funny is going on. More in the office setting, you could use random drug screening and pill counts. Opioid treatment agreements, all of your controlled substance prescriptions will come from one provider. That could be part of a opioid treatment agreement. And now here in Maryland, we do have the prescription drug monitoring program, and hopefully soon we'll be doing interstate data sharing too. So all strategies that we can use to make sure that patients are using their opioids responsibly. Also, there's been more emphasis on drug take-backs lately and safe storage of medications in the home. So educating people that diversion does occur. People do steal medications out of a medication cabinet in the bathroom. So letting people know, keep track of your medications, lock them up, do whatever is necessary to prevent the diversion. And then there's some required strategies, such as the REMS program for the extended release and long-acting opioids. So components of the REMS program, we have a medication guide or patient package inserts that are required to be given to the patient at the time of dispensing, and then a communication plan to educate healthcare providers about the REMS requirements. and elements to assure safe use. So really a focus on training prescribers and dispensers, and then enrolling patients in a registry. All right, so what's the role of the pharmacist with the REMS program? So all dispensing pharmacists will be providing medication guides, and we should really be reviewing that with patients and or their caregiver as they pick up the prescription. And then another role for pharmacists is to inform the prescribers of which opioids actually are part of the REMS program. So only the extended release and long-acting medications at this time. All right, so which of the following statements is correct regarding the REMS program? B. Okay, great. So the short-acting opioids are not part of the REMS program, and patients are definitely not required to take a test. So just B is the correct answer here. We've got some challenges as we try and educate patients and providers about safe use of opioids. We really want to focus on improving the care of people who are experiencing pain, and that means educating them about the causes and the effects of pain, and also realistic expectations. So as Dr. McPherson mentioned, if somebody is suffering from chronic non-cancer pain, getting their pain to a 0 is not a realistic expectation, at least not now. So we've got to educate patients, we're here to help you, we're going to work with you on your treatment, but we cannot, completely eliminate your pain. And also, the many treatment options available for pain. So not just drugs, there's other things that we need to do as well. This slide shows some of the patient education components. So the different steps that patients can take to achieve pain relief, not just taking their medication, but relaxation strategies, coping mechanisms for people with pain, when they need to seek emergency care, different healthcare providers who could help them. There's a lot of, if we think about all the education efforts that we put into a person who's newly diagnosed with diabetes, there's a lot they need to learn about their disease and how they're going to manage it. And I think that we need to start looking at pain this way too. It's really something that we're going to manage in partnership with that patient. These are some resources that we can use for educating our patients about pain. And for us as pharmacists and healthcare providers, we can become certified pain educators ourselves. All right. Here's some prescribing guidelines that are useful to keep in mind when patients are receiving opioid prescriptions. The risk of abuse should be assessed before opioid therapy is initiated and also throughout therapy. There's some different tools that can be used, such as the opioid risk tool from Dr. Webster, and also the SOAP-R is a screening tool that can be used prior to treatment initiation to assess the risk for opioid abuse. Also some patterns that are suggestive that something bad is going on here. So if a person is experiencing adverse consequences or negative consequences as a result of their use, as I mentioned, that would be classified as abuse. So if they're becoming irritable or preoccupied with the drug, that would be suggestive there's a problem going on. Also impaired control over use and compulsive use, and preoccupation with their use due to craving. All of those would be kind of red flags that something bad is going on. More of the prescribing guidelines. So watch for and treat concurrent psychological disease as it occurs. So multiple studies have shown that patients who have comorbid depression or particularly post-traumatic stress disorder are at an increased risk of opioid abuse. So watching out for that and treating as necessary is important to reduce the risk of opioid misuse. If it's necessary, and it often is, to switch a patient from one opioid to another for a variety of reasons, it's really important to use conventional conversion tables and to make that switch very carefully. So we can calculate an equianalgesic dose that may not be a starting dose for a patient depending on how their pain is controlled. And Dr. McPherson's clearly the expert on that topic. And it's also important to avoid combining benzodiazepines with opioids. It's really like combining an upper and a downer, or two CNS depressants, two downers. But that can really increase the risk for respiratory depression and sedation. Methadone should also be started at a very low dose and titrated very, very, very slowly because of its long half-life and potential for toxicity. Patients with sleep apnea have a higher risk for opioid toxicity, particularly sedation and respiratory depression, so they should be monitored especially carefully. Patients who are on opioid therapy for long term should be instructed to reduce their dosage during upper respiratory infections or asthmatic episodes, again, because of the increased risk for respiratory depression. And long-acting opioids should, of course, not be used as a PRN or for acute pain. Arizona actually released some dispensing guidelines for pharmacists on how to ensure that opioids are dispensed in a safe and responsible manner. And some of their guidelines are shown here. They recommend, of course, using prescription drug monitoring programs as they're available, and to use clinical judgment about contacting providers. So if a patient is presenting with multiple lost prescriptions or extremely high quantities or something that seems a little fishy, as Dr. McPherson mentioned, trusting your gut, that would be the appropriate time to contact a prescriber. And also other pharmacies should be contacted as necessary. So if you as the pharmacist decide not to fill a prescription, the general recommendation from Arizona was to alert other pharmacies within a 5-mile radius and let them know to be on the lookout for that prescription. Arizona recommends requiring government ID for all new or unknown patients with an opioid prescription, and of course not filling suspect prescriptions. And as I mentioned before, all patients should be educated about proper storage and disposal. We talked a little bit before about the symptom analysis for patients in pain, but it's important to ask really all of these questions when assessing a pain complaint. So what brings the pain on? What makes it worse? What makes it better? What have you tried before? How did it work for you? What's the quality of the pain? Is it aching, burning, constant? Does it come and go? Does it move anywhere? Is it localized to your knee, or does it radiate down your whole leg to your foot? How severe is it? Are there particular times of day that it comes on? Is it, getting worse right before you're about to take your next pill and you're experiencing some end of dose deterioration, or is there something else that brings it on? And are there associated symptoms? Okay. All right. So as we move on to deciding when opioids are appropriate for pain, I'm going to turn it back over to Dr. McPherson.
Dr. Simoneau. I think those 8 prescribing guidelines that you covered are critically important. I think if every pharmacist could remember those 8 guidelines, we could save a whole peck of trouble. I've heard Dr. Webster say, do you know how many lives pharmacists could save by just adopting the core value of never to dispense more than 10 milligrams of methadone as a starting dose per day to any patient who is opioid naive? I actually think that's too aggressive. I would never go over 5 milligrams a day for a patient who's opioid naive. Methadone is a wonderful drug, but it's involved in such a small percentage of the overdoses, but it causes 30% of the deaths. So when we start too high of a dose, people feel great day 2, they feel fabulous day 3, and then they're dead on day 5. So never ever dispense more than a 10 milligram starting dose per day on an opioid naive patient. So important. And be so careful with the benzos and the opioids. And I know everybody and their dog is on oxycodone 30 and Xanax. That's a recipe for disaster. If it's methadone and a benzo, you don't even get snoring as a warning shot. Snoring is a sleep disordered breathing pattern that warns you of impending toxicity and potential death. So important. So again, getting back to, is an opiate even right for this patient? Probably for chronic somatic and neuropathic pain, musculoskeletal, peripheral neuropathy, postherpetic neuralgia. Probably not. It's going to be your chronic visceral pain. I'm not talking about liver cancer. Of course, that would be appropriate. But things like pelvic pain, abdominal pain, fibro. No, opioids are not the answer for fibro. And I do have a couple of patients who do get an opiate for fibro, but basically at that point, in that patient's life, it's a palliative care intervention. It is not really usually appropriate. And headaches, oh my gosh, there are like 8,000 flavors of headaches, and opioids generally are not the answer. We are the last line of defense in protecting individual patients and society as a whole. We have to monitor prescriptions, certainly for falsification, alteration, so stealing prescription pads, altering a doc's prescription, calling it in, and the prescription drug monitoring is going to help us with the doctor shoppers. So be suspicious of, but it's not necessarily a slam dunk, high quantities. But again, high quantities of an opioid without a co-analgesic on board is a red flag for me. Patient comes back too soon. Now Dr. Simoneau talked about addiction versus pseudo-addiction. Pseudo-addiction is somebody who is consumed with worry about their drug. That could be that somebody's not treating their pain appropriately and they're just giving them Percocet after Percocet, or I guess Vicodin and Lortab constantly. They should be on long-actings probably, and they should be on a co-analgesic. But the patient is so worried. Like, I know doctors who will write on the same day of the month for the prescription. But if it's a 31-day month and they're writing for a 30-day supply and you are truly opioid dependent, you could actually go into withdrawal that last day of the month. So I write prescriptions, which the doctors sign, of course, because I can't legally sign them. I write them for every 4 weeks. Every 28 days I give them a new prescription, and it gets through their insurance and the patient won't run out. I think this whole thing could be largely improved by closer scrutiny altogether. And, you know, how many of you are in favor of rescheduling Vicodin and Lortab to be C2? Raise your hand if you're in favor of that. Raise your hand if you're not in favor of that. And the rest of you, what, are in the bacon coma? What's with that? I will have you know, this year, my birthday, August 31st, was International Bacon Day, and I was very proud of that. But I'm in favor of that. I think we should reschedule Vicodin and Lortab. You know why? Because I think we need a closer level of scrutiny, starting with the prescriber. I think the prescribers need to up their game. And you know what? We need to up our game, too. Obviously, you know the drill. You know all these things. I do believe in monitoring. You can step from behind the counter if you're in the community or even in the hospital or wherever you work and follow the 4 A's. Just asking the questions, how has your pain been? And I document this in my note in my clinic. How has your pain been on average? What was the best? What was the worst? Are you getting better? So is it clinically significant pain relief? The other A is your activities of daily living. Can you do more stuff now on this analgesic regimen? And if I can document that, I feel much better. You know, I know this patient is on 40 milligrams of OxyContin a day, but now they're able to sleep through the night, and when they awaken, they're not in pain. The patient was able to go back to work. I take care of a guy who comes from another university care setting, but his physician's not comfortable doing it, so they send him downtown to me in Baltimore. Oops. And he had lost a lot of weight because he actually is a car mechanic, and a car fell off that little thingy and cut off his foot. They were able to super glue it back on, but he has, wow, really impressive pain. And if you don't believe him, he'll take off his shoe and show you. You just want to, like, ugh, poke up with your eyeballs. It's like, ooh, take it away. Don't show me anymore. That looks really, really painful. So I put him on methadone, 2.5 Q12. He came back a week later, which is a very subtherapeutic dose because he's a big guy. And he said, I gained 5 pounds this week because I'm not so nauseated from the pain. I was able to eat, and I was able to sleep for 4 hours at a time before the pain woke me up. That's huge to put in my note. So it's activities of daily living. Adverse effects, the normal stuff, nausea, vomiting, constipation, itching. With methadone, I mean, I'm going to ask about, did you faint this week? Could it be QT prolongation, putting at risk for an arrhythmia? And the 4th A is aberrant behavior, purposeful oversedation. People actually tell me, I was in a lot of pain and I was so unhappy because of the pain, I took an extra Percocet because it made me sleepy. This is not a good look. This is not good. Negative mood changes. They look like a drunk monkey. This is not good either. I mean, people actually have the nerve to come into the pharmacy. Hi, are you stupid? Really? Really? You're going to go to the pharmacy high. They're having accidents, asking for early refills, increasing the dose without authorization. These are all bad looks. Additional, you know, contact with the street. I was arrested. I was abusing alcohol. I'm hoarding. I was arrested by the police. Other strategies, urine drug testing, opioid agreements. If you are taking care of a patient, I think it's appropriate to call the prescriber and say, I'm the community pharmacist. I would like to know, do you have an opioid agreement with this patient? And could I get a copy of it, please, for my records? I mean, we're all part of the healthcare system. Dr. Simoneau talked about calling the pharmacies in a 5-mile radius. We are all protected under HIPAA to talk to other healthcare practitioners. Absolutely we are. If you are involved in urine drug testing, which is kind of a specialty here, be aware of the metabolic pathway. I mean, if somebody's taking certain drugs, you'll see other metabolites. If they're taking codeine, you're going to see morphine in their urine, and that's appropriate. So, which of the following statements is correct regarding opioid prescribing guidelines? There are validated instruments available to screen patients for potential abuse. Most prescription analgesics used in an unintended fashion were obtained freely from a friend or relative who's sharing the love. Benzos plus opioids increase the risk of adverse effects. A and B, or A, B, and C? All the above, absolutely. So Dr. Webster on his website, zerodeaths.org, has these 6 patient counseling points, which, you know what? It would not take you but 30 seconds to grab every patient who you dispense an opioid to and say, I need to talk to you for 30 seconds. Never, never, never take a prescription painkiller unless it was prescribed to you. And do not share the love with anybody else. And do not lose your mind and start drinking alcohol now. Do not take more than was prescribed. If your pain is not controlled, call your prescriber. Do not be a freelance pharmacist and take this on yourself. Use of other sedatives or anti-anxiety medications can be very dangerous. Don't use it as a sleeping agent. This is not a sleeping agent, because you know what? You could be doing the deep sleep, if you know what I mean. And you know, I tell my patients, you know what? Do you store your money on the kitchen table? And they look at me like, what, are you crazy? Of course I would never keep my money on the kitchen table. Well, then you don't keep your medicine there either. And you don't keep it in the medicine chest in the bathroom, because people come and say, hey, can I use your bathroom? And who can resist when you go to the bathroom in a stranger's house, checking out the goodies in the medicine cabinet? They may have something really cool in there. And then they took home a lovely parting gift. I think pharmacists are extraordinarily well positioned to do public education. Educated people can take steps to avoid pain. Just good self-care, to give appropriate advice, advocating for patients. I mean, I'm a huge patient advocate. The biggest thing I do when I talk to lay groups is I say, let me teach you what your doctor should be asking you about your pain, so that if your doctor doesn't ask you PQRSTU, you can say, hold up there, cowboy, stand on their foot and say, it's your job to listen to my pain story. So let me give you this information, even though you had the bad manners not to ask me about it. So here's a piece of paper I actually thoughtfully filled out prior to our visit, so you could have the 411 on my pain situation. And I think pharmacists are huge patient advocates and pain educators. We do this all the time. So inform, educate, and empower people about public health issues, which are both pain control and drug abuse and misuse, is one of the 10 essential public health services every public health agency is expected to provide. And we are public servants, absolutely. Public education enhances the effect on all major influences, as shown here. So who can we educate? We can educate the prescribers, the nurses, psychologists, our colleagues, dentists, PT, OT, anybody who will stand still. I mean, I know sometimes, you know, I call the seizing the teachable moment. I'll go to the bathroom and somebody say, hey, I recognize your shoes. Can I ask you a question? Sure, what the heck, I'm not doing anything else. So I think pharmacists bring so much to the table, and you know what? We are the watchguards for society. We really are. This is up to us. We have to partner with prescribers to curb both of these important problems. We have to really get our arms around the therapeutics of pain. So do the prescribers. We rock. I mean, we are it in OTCs. We wrote the book, literally and figuratively. We have to use REMS. We have to use prescription drug monitoring. I'm so happy Maryland finally got with the program, and that's going to be huge in doing this. And educating, and I want to see everybody in the room this time next year be a certified pain educator, paineducators.org. Questions? Yes. Hold on one second. She's coming with the mic.
You mentioned in one of your slides health beliefs, opioids and patient-related variables. Mm-hmm. What are health beliefs?
You know, when I talk to a patient and I say, I'm thinking about methadone, they're like, ooh, methadone, no. My grandson takes that stuff because he was using heroin. Are you saying I'm a drug abuser? I have to do some tall talking. So people have beliefs about methadone. I say morphine, they think cancer. I say OxyContin, they say Kentucky and West Virginia. No. We're not going to go there. So people, you know, even at end of life, people believe I have to suffer with the pain so that I can go to heaven. Well, my personal belief system is that's a load of baloney, but that's just my belief system. So if you don't explore what a patient thinks about their disease and the drugs, you know, you could tell them one thing, they're going to go home and do something else. You could tell them till the cows come home, if you're written for 1 Q4, if you take 3 Q4, you're going to kill yourself. So it's important to do that education. I'm very clear to say, look, I'm not your mother. I have one kid, and you know what? She's enough for me. I'm not your mother, but I'm here to give you the education and the facts. You're a grown-up, but there are choices and there are consequences. Anyone else?
Hi, it's Sue again.
Hey, Sue again.
Hi. Well, no one said anything about pseudo-addiction.
Pseudo-addiction is what I was just talking about a few minutes ago, distinguishing it from addiction. Pseudo-addiction is somebody who acts like a drug seeker. It's like the person who gets 30 days of drugs in a 31-day month, for example.
Right, that guy.
So it's somebody who's like, oh my gosh, I need my drug. And if you can't tell the difference between somebody who's addicted versus pseudo-addicted, the answer is sometimes to give them a little more drug.
Right.
or to take a big old step back and say, do we even have the best drug regimen cooking here? Because, I do wrestle with that. If somebody's got maybe some yellow flags, maybe not red, do I really want to increase it? What should I do? I generally will give the patient the benefit of the doubt. Have I been taken for a ride? Absolutely. But sometimes increasing the dose a little bit, then they'll stop. They'll chill out a little bit because their pain is better controlled. But what I'm very careful to monitor for is decline in functional status despite a dose increase. So they're not doing things better despite increasing the dose.
The only other thing is, the reason I disagreed with you about hydrocodone is, normally if we make a decision, what are we going to use instead?
I'm afraid they're all going to turn to tramadol, which I think is an only okay drug. I can't get all excited about tramadol.
That's my point.
Yeah, tramadol, people abuse that too, absolutely. It's got the same side effects of the opioids.
It's a
but
mu receptor agonist.
only 1/6,000th the potency of morphine, so I can't get all misty over that. Its main effect is to increase serotonin and norepinephrine, which makes it a fine co-analgesic. Yeah, but I think the whole answer is closer scrutiny and a better job starting right at the prescriber's office. They need to bring their A game and not just use their 7 minutes to give everybody a script. And patients don't want to hear, instead of giving you Percocet for your fibro, you need to get to the YMCA and take an aquatic class. They don't want to hear that at all. They would rather eat a bug than do that. It's far easier to take Percocet. Anyone else? Yeah, Bill.
Phil, wait. Yet prescription drug abuse is increasing. How can we say it does any good at the cost of hundreds of millions of dollars?
That's a tough one. We're seeing all these monitoring programs, but we're still having abuse and diversion. I think that you saw Dr. Semino showed the slides with the increase in the use of the opioids. I think the opioids are not the answer as much as we have seen the growth of the opioids. And while I don't favor a state-imposed limit on the amount of an opioid, I'm a big believer, maybe it's because I work for a school of pharmacy, that education will set you free, but I don't like limiting pharmacies' quantities and things like that are artificial. I think you need to get to the root of the problem. Better diagnosis. Maybe we need to train more pain practitioners. I do like the prescription drug monitoring. I think that's going to be a big help. That's hard evidence right there. And if everybody in this room doesn't do it, then you're 7 kinds of cray-cray. Yeah, I don't know the magic answer. If I did, I would be rich if I had that answer. I wouldn't be standing here. I'd be like in Bermuda right now or something. Paris, maybe. I don't know.
So I'm going to throw this question out. I see some pain specialists stamping on their prescriptions, fill with insurance only, and that's kind of legally gray to me because it's just a stamp they put on there.
It's also kind of immoral to me, too, and my own clinic does that, too. So I was hopping up and down from foot to foot and say, how can you do this? We're working with inner-city patients who sometimes don't have 2 nickels to rub together, and I use methadone because it's so darn cheap. And I've been tempted to quit my practice because the lead physician does not believe in doing pain management in the community. So I almost had a stroke, and because I kicked up such a fuss, now all of a sudden I'm getting all these pain patients. They assured me that if the patient did not have insurance, they would back off on that. But because I don't think that's morally, ethically appropriate. Whether it's legal or not, I don't know. I'm not a lawyer either. I don't even play one on TV. Question over here? Hold on one sec. She's coming with the mic.
Not a question, just a statement about this prescribing guidelines, avoiding benzodiazepines with opioids.
Yeah.
We always see.
You always see it, absolutely. I even recommend it in hospice all the time. Can you believe it? But I'm just saying, let's view that with a jaundiced eye when you see the prescriptions for a bucket full of short-acting Oxy-30s and a bucket full of Xanaxes. I think it's worth, pharmacists have been sued for dispensing those combinations. So I know you can't go cray-cray like, some chains that now insist you call on every single C2 that walks in the door. And I don't agree with pharmacists saying we don't believe in ever filling a C2. That's not morally, ethically appropriate in my mind either. But if you are seeing egregious things, I think it's worth a phone call. Use your clinical judgment as to whether or not you dispense it, but I think also, in addition to education, documentation will set you free too. So I would document my behind off. Any last questions before I turn it back? Thank you so much.
I wanted to get one. So I'm Laverne Nacia with the Maryland Board of Pharmacy, Executive Director. And I wanted to thank our speakers, Michael Bear, Dr. McPherson, and Nina Sanino. Mo?
Yes,
for
that way I'll
presenting
have a
today.
picture of each
I
person.
think that this is a really good jump start for this new initiative. I also want to thank the audience for their enthusiastic
When you get
Um,
registered.
reception of this program and interest in trying to find out what they can do to help
Okay, well,
protect
I have
Maryland
to- I'm going
citizens
by
better.
the dates of when you
I
registered. because
wanted to
yours-
note
yours
that
was
we're going to have this
53.
whole session videotaped, or it has been videotaped, and we'll put it on our website
Right.
as a link in the very near future. And I wanted to remind everyone about the CE evaluation survey in the back where you can go online so you can get your credits. You will have to go online in order to do that. Also, I wanted to note that Dr. Herrera, Deputy Secretary for Public Health, sent her apologies. She had some problems this morning and was not able to make it, but she truly wanted to be here and said, Mike, I'm sure you did a great job, as he did. Any other questions for the good of the cause before we close? Okay, thank you all, and have a good day.
And could I see all the honorees up front? I want to take an individual picture of each person.
Okay. All honorees. Can I have your attention one more minute? I just wanted to acknowledge Zeno St. Cyr, Lynette Bradley Baker, who's the chair of the Public Relations Committee, Dave Jones, who's also a member of the Public Relations Committee, for their putting this together with board staff, Janet Seeds and Patricia Gaither. And I apologize.